Matthew Holt, GCB Spotlight. I am here with Bevey Miner, my friend, who is these days, looks like a shield. That's the next cool move. You are actually at eFax. Okay, Bevey, we talked about a year ago on the record, and you weren't called eFax, so what the hell happened?
Well, interesting question, Matthew. The company is Consensus Cloud Solutions. And the company's always been Consensus Cloud Solutions since we spun off and went public ourselves, right? You'll notice at our booth, we've got the eFax brand, right? And the reason we are showing up, and it's eFax by Consensus Cloud Solutions, the reason we are showing up as eFax is because this year at HIMSS, we really wanted to set the record straight that digital cloud faxing is not the problem with interoperability. Paper faxes are, but digital cloud faxing is not the problem. The problem is all this unstructured data. All the unstructured data that happens with faxes, that happens with scanned images, that happens with TIFF images. All that unstructured data can't be queried. It can't be a part of TIFCA. You can't query what you can't find. Now, cloud faxing is send and receive all day long. And we do that very well and have been doing it for 27 years. About 3 years ago, we introduced an intelligent extraction solution. And that intelligent extraction solution doesn't even have to start with a fax, but it allows the find piece to actually become the critical thing that we need to do. CMS defines interoperability as send, receive, find, and integrate. Faxing technology, send and receive all day long, can't find. So once we introduced a find and intelligent extraction solution, we can fire up TEFCA. I've talked to a lot of regulators, including Dr. Thomas Keene and including Amy Gleason with the CMS Aligned Networks. You can't ignore this pile of all this unstructured data and just assume that the industry is going to go magical. Everything's on fire. We're all fast on fire. We're all using fire. Because all of this stuff has really important patient information in it. What we want to solve in the industry is don't say we have to axe the digital cloud fax. Let's axe the paper fax machine. This isn't going to go away. In fact, it's growing pretty big, especially as we get rural health off of paper fax machines. The next level of maturity is digital cloud faxing. From there, once it's digital, now you can do all sorts of things on it. When we introduced electronic health records back during Meaningful Use, right? And I was at Allscripts at the time. Our dream then was that we would just take this paper record and we would kind of personify it into this electronic health record. So we could just get rid of the paper. Once we did that though, and there were discrete data elements in that EHR, we could do pop health. We could do clinical decision support stuff. We could do efficacy. All sorts of things that we can do because there's discrete data elements now inside that electronic health record. That's what a digital fax will do with the capability to do intelligence on top of it. So we want to really make the industry understand that that's not the problem. The fax is not the problem. Extracting it and getting rid of all that unstructured data is the solution.
Okay, so since we last talked, I've had some journeys around the healthcare system. Let me tell you, you mentioned your daughter is a prosecutor in California. I'm one of these prosecutors myself. Let's take the main district hospital, right? They were sent a referral from my lovely primary care doctor, One Medical. Somehow the referral from One Medical got into the Blue Shield system, created a prior authorization, so I can have an echocardiogram. I've written this up on my blog. You know what's coming next. I call the number on the referral that One Medical wants me to call for the Marin Health cardiac imaging center, and they go, we don't have any of this referral. I say, no, they send it to you. I see the PDF. And I go back 2 weeks later, and they go, no, we don't have the referral. So finally I call them, and I say, can I email you the referral? I download the PDF, and I get who somebody or email it to, and then that person goes, oh, this is a cardiology imaging referral, not a regular imaging referral. And you transfer over the cardiology, which is of course in the same building. But ignore that for a second. Yes. But here's where it gets interesting. They say, great, we can only take ads. We can't take an email. They don't tell me it was because HIPAA wouldn't allow it.
Right,
Quite
that
funny.
makes sense.
Right. But then I downloaded, it might have been eFax, I downloaded your consumer product. It was somebody's fax product, but I had to download a trial of it and cancel. So I faxed the thing. So now they've got a referral, which was typed onto a PDF, typed into a document, may or may not have written a piece of paper. Presumably somewhere they have the prior rules as well. This has now arrived, and now they can actually
Schedule you.
They can now do something with my. What is wrong with that picture, and what can eFax do in that picture to sort of fix that and get the data out of it that's required to help you?
Well, a lot of things are wrong. Number one, you're going to get latent treatment. You're going to get frustrated as a patient, and your health outcomes. You may even abandon it.
Well, that's actually, I was about to abandon
Yeah.
it, but I thought I should keep going. I actually do have a problem.
Yes, but your health outcomes could actually have been horrific,
I
right?
might have dropped them having never had the echocardiogram.
Yeah. But you bring up a really interesting use case that we're doing today with imaging centers. So hospitals that own their imaging centers, or IDNs that own imaging centers.
This imaging center, by the way, has both in the same building as the cardiology imaging and the MRI,
And the provider
and
the
the
MRI.
regular imaging, and
So it's a radio.
very
Yeah.
different numbers,
Yes,
different,
God.
and one took the email and one took the fax.
So as an example, if the order is coming in as a fax, and this is an actual real use case that we're doing, we intercept the fax, we pull out all that structured data, all the patient's demographic information, we pull out what the order is for, and let's just say it's a mammogram, but it's a mammogram with contrast, right? We map it into the radiology system so that they can see the order without data entering anything. If it would have come as a fax order to them, somebody still has to data enter it. Or it's sitting in a pile of all these orders that they've gotten. Once it's extracted data, and it can be mapped into the imaging center, the RAD system, the RAD-IS system, and they can see, because we read, this isn't just a mammogram. This is a mammogram with imaging is what is on that order. Now they can see, okay, do we have a mammogram with imaging, with contrast? They need a mammogram with contrast. Excuse, I'm saying imaging. Of course, it's an image, but a mammogram with contrast. And do we have that machine? And do we have that machine available? And can that machine schedule the patient for Monday, Tuesday, Wednesday? And once all that's done, no human has actually touched this at this point. It's getting in, it's getting looked at, and it can actually be mapped into their scheduling system, so you can send a text message directly to the patient within 24 hours. We got your order, and we have opportunities for you to come in Monday, Tuesday, Wednesday. All of that is because we pulled out the structured data for that image. And for every day that a patient that is expected to get the next level of care, a mammogram or some sort of imaging, every day, 25% of the trust in the system for the patient is eroded. That imaging center needs to get that referral because it's their lifeblood, right? The patient's going to go somewhere else. You could have just said to the doctor, they haven't called me, find another place for me to go.
So in this particular case, right, they asked for referral quite small. I don't know how they. I assume the referral was being faxed over from the medical to the maybe.
Probably.
So in some other way. So if they had plugged in eFax somewhere in the middle of that, right, and it didn't go to their fax number, it went to the fax number, became the thing you read it, went to the thing they should be taking it automatically, and they clearly haven't done that yet, right?
So the product that intercepts that is called Clarity. That's our AI data extraction piece, right? And once you've created all these discrete data elements, I mean, let's say the imaging center wanted it all on fire. They needed to keep it in fire so that it could have be mapped. We can send that as a fire message. We can send that as fast on fire. We can send that because we have a backbone that is actually an interface backbone. It's a semantic interface backbone. Once you've got all this extracted data, now you can do prompt questions on it. So if you've got the extracted data going into the radiology IS systems, you can say, we need to see all of our patients that need to have an image with contrast because those machines are sitting without being used, and we need to get those patients in fast. And you can add prompt questions just like you would for any generative AI solution.
So I'll tell you something amusing, which leads to another question. So eventually, after the fax goes through, somebody calls me back, and of course, I don't know if the phone's going to ring, but I have the voice, so I see the transcription of the voicemail, and they've arranged me the very next appointment at campus for like 3 weeks. It happens to be in Santa Rosa, which is an hour from my house, not the one next to my house. So I think, well, I can go to my chart and maybe I can change it. So I go to my chart, and my chart shows me the appointment. It does not show me. It does not give me the ability to change it. It does give me the ability to set an appointment, but only if I want the mammogram. But it does lead to a question, right? So you have the faxes going back to these departments. So this one is still very manual. They're very manual entry. They're setting a manual appointment for people having a machine that comes back.
Right.
The next day, I change it to one the day after the one they sent me for. I can have it 10 minutes from my house, or an hour from my house. But there is, the backbone of Epic, maybe what's all scripts? I can't remember the name. But
Sure.
Oracle, whatever these things are called, right? And there's a lot of information sitting in there, and there's people trying to get it in and out, different methods. It's not all electronic.
Right.
It's something's fax, but not electronic. How does what you're doing, eFax, play into that?
So what's interesting is that we have a really big effort for patients' access to their data. My chart as an example, right? This administration, Trump's promise and campaign was that every American would be able to access their medical information, right? Yeah, well, it's there. And now we have a bunch of pledges that are happening for patients' access to their data, right? And the QR code that you can put underneath, and there's your patient's access to their data. What do you do with all the unstructured data where the patient has a lab result in here? The patient may have some, clinical information that's in there. The US CDI data set that gives the patient all of their entire history, their summary, is sitting in unstructured data. And you can't query that. It can't be queried because it's not queryable. So the QHINs are only operating on a small subset of data that is FHIR-enabled and structured data. It's going to be biased. It's going to have missing pieces of information. And the patients are going to think, oh, here's all the information I need. Until they drill down to say, 2 years ago, I had my hemoglobin A1C was like pre-diabetic. I want to go find that. And it's an unstructured PDF somewhere. So for them to search through it, it can be a challenge. When you look at an electronic health record, there's a lot of PDFs that are attached to the patient's chart, right?
I was just looking at mine, both medical and lab and Epic. PCSF all have different lab structures. Some of them some of them they processed internally and can show me like the number becomes a nice little yellow, red, green thing. But I'm not sure they're all in one place. Right? And we have a lot of work to get that.
We have a lot of work to get a common record for patients. I mean, I have two my chart accounts. Now it's easy because you can say I want them to link.
Right?
Yeah. Right? But I also go see another system that doesn't use my chart. They use Follow My Meds or Follow My Health or something like that. And it's not integrating as it should. So I know the promise is great. And I remember the days, and you probably do too, Matthew, where every patient was going to carry around a USB thing, right? But they were going to carry this around and they just put it in a machine. Yeah. Or we're going to have this magical card. Yeah, right. Right. But I do think there's promise, and I think the promise is to really recognize that here's a whole bunch of data. I look around at a lot of these companies here at HIMSS, and they boast that they do workflow enhancements, that they can do prior authorizations, that they can do, population health. When I ask them, what are you doing with all the unstructured data? They go, we have an OCR solution. Whenever I hear we have an OCR solution, that's not really extracting data at an intelligent level. OCR knows that that's a B, E, a V, and a Y, and my first name doesn't even know it's a name. If you use intelligent extraction, it does contextual. It says, go find me the name of this patient in this form, which could be in the upper left-hand corner, could be down in the bottom. It really understands how to ask the right kind of questions, and OCR is kind of a gap. So we are actually playing a role where we can create some very sophisticated intelligence off of all this unstructured data. So many of these workflow solutions can have better data going in. And, you know, I mean, I've talked to Dr. Thomas Keene, head of ONC or ASTP ONC, and I said, do you really want to make TEFCA successful? You got to talk about how we can manage getting all the unstructured data into the, into a FHIR-enabled TEFCA framework. And rural health, and you and I have talked about this because it's been a passion of mine. Health equity has been a passion. Rural health can't rip and replace. They can't support all the FHIR-enabled, solutions they're supposed to support. The CDC in their data modernization now is saying that all electronic case reporting has to be done via FHIR. Well, I mean, the community clinic, they definitely need to populate these repositories, these databases, and otherwise it's going to be completely biased, right? And then, I mean, if you look at the prior authorization rule, 57, going live January 1st for Medicare Advantage patients, what is that substance abuse clinic that needs to now ask for an authorization so that that patient can stay in another, 90 days of treatment? They can't send a FHIR-enabled prior authorization to actually be able to have that approved. We intercept their fact. We say to them, and we do a lot in rural health, we say to them, just keep doing what you're doing. We'll intercept it in the middle, and we will send that as a FHIR prior authorization. It's important the industry understands that it's not, you have to recognize that there is not tech equity with every provider.
All right, give me your forecast and prediction. There's all these different holes that you've got in unstructured data, and there's something else flying around. There's ambient AI and people asking products and what questions those might be putting their reports in the ChatGPT and Gemini as well. Do you think that the consumer patient to smaller provider and any provider experience is a lot better in 2 years? Or do you think we're still finding this? So, I mean, basically asking, is Amy Gleason and the team going to succeed? Or are we going to be in war here and arguing about this in 5 years' time?
I still think healthcare is transactional. If everybody was in a closed system, everybody talked Epic, it would be great. But we don't have that kind of a system. And this is an administration of deregulations up for whatever you think you can do from an innovation perspective. When you have a regulation, a pretty tight regulation, you see solutions that will actually help providers and other technology companies to satisfy that regulation, which is happening with the prior authorization side, which is why we are really helpful for those that don't have FHIR resources to send it into for prior authorization. But with deregulation and pledges, I think in 2 years, if you were to give me the same interview, we would see some baby steps. And also because there's a consciousness among patients, I can actually do a lot with AI. I can push hard on my docs. I can say this is the best treatment, and not always even use Western medicine to do that level of treatment. They're going to hold a ton of power, and with that power, patients are going to say, I have a responsibility to take care of my health. And so I think that's going to move faster than we even thought, especially with ChatGPT Health. Patients are using Gemini Pro. I use it. I use it all the time.
I use it a lot. It's read a lot of my reports, and I have a lot of questions and answers for it, but also, you know, you hear my doctors about it, and they're definitely going to shape up. And I think there's also, I mean, I've talked a lot about this, you know, as well as some of the people who have been dragging their feet on getting this stuff done, and you obviously want a solution that's a sort of very inconvenient solution for these people who are on the edges. Yeah, they're not going to go over this crap in a couple of years because people are saying this is just more fantasy being built 3 referrals in a row.
Right.
You know, it's just not going to be. So I'm hopeful, you know, and Amy Gleason and I joke about our differences, but I'm not joking. But,
You got a joke.
This is an area where, you know, I think there's a lot of consensus around we've got to get some stuff done. Obviously, you know, you and I have been doing this long enough that we remember when you couldn't get your data anywhere, and now everyone else is suing you. It's been suing each other about.
We are about data, about information blocking. Yeah. And, you know, the patient, they don't care what the pipes look like at the back end. The docs don't even care. The docs are saying, I don't care what you do and what you as a technology vendor can bring to me. I don't need to see all the stuff flowing through. I just need to have information so I can make a more informed decision and treat my patients the best way and make money doing it. I mean, look, we're going to have some headwinds here where a lot of hospital systems are going to have to deal with uncompensated care. And I kind of wondered, HIMSS is a little light this year. And I thought, I wonder if they're actually just looking at budgets and they're saying, look, we can't give you the same IT budget that you've had in the past to go shopping. We're going to have to shut down service lines. We're going to have to shut down behavioral health. We're going to have to shut down women's health to just manage all the uncompensated care that we're going to have to deal with. So that's a new world we never thought we'd see. But I think we got to weather through that too.
See how it goes. I've been thinking Bevey Miner, everyone's healthcare and eFax, like consensus cloud solutions. That's a good enough. Bevey, thanks for your time.
Thank you, Matthew.